All right. Hi, everyone. Good afternoon, and welcome to our initial meeting of the new Cost Growth Target Advisory Committee. Really excited to see you all here today and to restart this public-facing committee after the last 6 months. So welcome, and we're going to share a whole bunch more information about our work together, and all of us will have a chance to share our excitement and sort of set the stage for this body of work. So I think I've met all of the committee members at this point, but I'm Sarah Bartleman. I'm with the Office of Health Policy at OHA, and I am the Cost Growth Target Program Manager. I'll be facilitating today. Want to go through just a couple of housekeeping notes before we jump in. So we are in a Zoom meeting. Committee members, if you have not already, please put your name, your organization, and if you would like to, your pronouns in your name. That's really helpful for us in facilitation, especially as we're all getting to know each other. You are encouraged to be on video. You are not required to be on video, especially if you need to save bandwidth or have a bad connection, but it's really helpful to have committee members on video so we can get to know each other. Please keep yourself on mute, especially folks, members of the public who are listening in. Please keep yourself on mute until we get to the public comment period. We are leaving the chat open, so if you're having any questions or any technical difficulties, feel free to reach out in chat and we will address that, but we're also going to try to keep the discussion in the verbal discussion and not have a bunch of side conversations in chat today, and we'll see how that goes. We will mute you on our end if it looks like there's any issues with that. The meeting is being recorded. We will post the recording on our webpage in a couple of days. We will also provide a written meeting summary in the future. The slides, the agenda, the draft charter, and the written public comment that we received this morning, you all received that in your email from me directly, and they are also all posted on our webpage as of this morning. And finally, we will hold public comment at 4:45 today. Okay, Gerondy, next slide, please. Just a little bit of an overview of today's agenda, and this is a little bit of an oddity. So normally we would start our committee meeting with introductions and checking in, but because we are accommodating East Coast schedules today, we're going to go a little bit out of order. So we're going to have some introductory comments from Jeremy Vandehay and Bill Kramer about the program and how it aligns with OHA's priorities and the Oregon Health Policy Board priorities. Michael Baylett from Baylett Health is going to give us an overview of the national landscape of Cost Growth Target Program work and how this all fits together. I'm going to talk just very briefly about some of the details of the Cost Growth Target Program, although I think almost all of you went through the orientation sessions with us in May. Thank you so much for that. We're not going to cover a lot of that again since we did those orientation sessions. After all of that, then we will take a step back and do full introductions for all the committee members. We will take a break. And then we'll spend the second half of the meeting talking about our draft charter, talking about group agreements for how we work together, some of the expectations for committee members on the processes, our work for the coming months. We will also potentially select our co-chairs today. So some committee sort of housekeeping. We'll also set up the conversation and the work that we'll be covering in July and September for this year. We'll hold public comment at the end of the meeting, and that will be it. So that is our agenda today. Any questions about the agenda or any of the housekeeping details before I hand it over to Jeremy? Okay, you all appear to be nodding your heads. Sounds great. Okay, so I'm going to hand it over to Jeremy Vandehay, the Director of Health Policy and Analytics at Oregon Health Authority, for some opening comments. And I think he will be joined by Bill Kramer from the Oregon Health Policy Board. I don't see Bill on video, but maybe I'm missing him. So Jeremy, all yours.
Great, thanks, Sarah, and thank you all for joining this committee. And it's an exciting day to kick this off. As I'll talk about in a few minutes, we've been on this journey for a number of years, and it's exciting to get to this milestone, and exciting to see the commitment of a lot of experts on this group to help us move this program forward. We've all seen a lot of this data. Unfortunately, probably many of you have heard me give far too many presentations over the last several years on the impact of healthcare costs in Oregon, and in particular that despite a lot of great work that we've been doing in the state and a lot that we have to be proud of, we haven't been able to get our arms around statewide healthcare costs, and they've been growing faster in Oregon than the national average. Oregon used to be pretty far down on the list in terms of per capita costs. We've now we've been growing over the last several years. faster than the national average. We've now surpassed the median and are in the top half of states nationally in terms of healthcare costs, and it doesn't appear that that's turning around. From 2013 to 2019, Oregon's personal expenditures on healthcare grew 34% compared to 27% nationally. I'd argue either one of those numbers is unsustainable, but unfortunately the challenge has been harder in Oregon. We've seen that the average annual cost of family health insurance premiums has been just under $20,000, which is pretty close to the equivalent of buying a new car for a family every single year. But instead that going to healthcare and health insurance. These high costs, I think, as you all know, put a significant amount of pressure on families, on employers, on businesses, even on the healthcare system, which is a large employer in the state and often the largest employer in most communities. It's also been a huge impact on the state budget and has limited our ability to make investments in other things that impact health, like education, human services, housing, a variety of other things that we often hear from the healthcare system are so critical to long-term health. We've been seeing it's sort of gone away in the early years of the Affordable Care Act, but lately there's been a lot more attention on medical bankruptcies. We're seeing the amount of uncompensated care increase. We're seeing medical bankruptcies generally increase. And unfortunately, that hasn't been shared evenly across Oregonians. Sort of like all things in healthcare, we see a much larger negative impact on communities of color. So to give you an example, in 2019, statewide average was 10% of people in Oregon reported using up all or most of their savings on medical bills, which is pretty astonishing that 1 in 10 people in the state used up all of their savings on medical bills. That number was 3 times that for Native Hawaiian Pacific Islanders in the state. Nearly a third had reported using up their savings on medical bills. There was an article that just came out from Kaiser Health News and NPR last week that some of you may have seen. That nationally 100 million Americans, 1 in 3, have medical debt, and that about a quarter of those adults had more than 5,000, and 1 in 5 expected they'd never be able to pay it off. So this work is critical. We know that this has been a really tough couple of years. This has been a huge challenge on the healthcare system. We know there's real serious cost pressures as we're seeing inflation increase and provider burnout, and that's real. We know that's real. And we also know that the impact on families is going to continue. And as costs continue to increase faster than wages in the economy, ultimately, at the end of the day, this impacts families and their ability to access the care that they need to be healthy. And so, we're very much continue to be committed to this program and think it's really a foundational element of the next wave of health reform in Oregon, and I think more important now than ever. We've been on this journey for a number of years. Some of you have been with us for the last 5 years, and thank you for your commitment to continue to be engaged on this. But a little bit of background: this program came about after a legislative task force was stood up in 2017. At the time, that task force was tasked with looking at whether Oregon should cap hospital prices similar to what Maryland does. The task force ultimately decided, for a number of reasons I won't get into, that was not the right path. But then did recognize that the costs were a significant challenge and we needed to do something, especially in the commercial market and outside of public programs where we do have more levers to try to contain costs. After looking around at a variety of things that states were doing, they ultimately recommended a statewide cost growth target was the way to go, and that we really needed to have one target that would apply across all markets and apply to as many providers and insurers as we could, and sort of get everybody in under the tent, if you will. In 2019, the legislature passed a bill, Senate Bill 889, that established the program. We had an implementation committee of 18 folks that were highly engaged for a year and a half through the pandemic. And ultimately, the legislature passed another bill in 2021 to implement the recommendations, and in particular, passed the accountability measures, which are the strongest accountability measures any state has around cost containment. So we've been on this journey for a long time and continue, and have had really strong support from legislators, from the governor, from the policy board, support from experts like Michael Baila and his team, who have been working with Oregon and a number of other states to launch similar programs, have had support from Milbank Peterson foundations. So I've had a number of real dedicated folks. Since Oregon first started this program in 2017, there's now, Michael, you can probably keep a faster count than I can, but we're probably approaching 6, 7, 8 states now that are in the process of launching similar programs. So we were on the cutting edge, but now have a pretty good crew of colleagues in other states that are also trying to launch similar programs. I just want to say again, the cost pressures we know in the healthcare system are real, and it's going to be very difficult, I think, balance over the next couple of years as we're trying to deal with provider recruitment and burnout and pandemic, and at the same time recognize that healthcare costs continuing to go up at 6, 7, 8, 9% is not sustainable for families. So as an agency, we're still committed, very much committed to this program and moving this forward. I know that all of you are, you wouldn't be here. And I think it's going to be very challenging over the next couple of years, but also I think this work's more important than ever. And I think that's really demonstrated by the fact that the implementation committee that helped design the program really continued its work through the pandemic with only a very short break, and really felt that on the other end of the pandemic, it's not like this issue is going to go away and we needed to continue it. I think we will, in the first couple of years of this program, we're sort of in a soft launch, if you will. Accountability is ramping up over the next couple of years. And I know that it's going to be, people are stretched within the healthcare system. At the same time, I think it's going to be really important, even if folks don't meet the target or we don't meet the target as a statewide, that we still have evidence out there that folks are trying, that they're committed to this program, that we're seeing good faith efforts. And we expect to be able to see that as we're getting the program started in these early years, even though the financial penalties and some of the other stronger mechanisms don't kick in for the first couple of years. From my perspective, it's critical that we see that folks are still committed to this and trying and demonstrating that. I think that will be important for the legislature. I think it'll be important for the next governor, for whoever comes in, who will also be dealing with this issue. So thank you all again for being here. Again, we can't do this work without you. We're excited to get this off the ground, and I will turn it over to Bill, if he's on.
Thanks very much, Jeremy. And thanks, Sarah, for all the work you've done to put this together. And welcome to the members of the Sustainable Cost Growth Target Committee. I'm Bill Kramer, a member of the Oregon Health Policy Board, and I'm the designated liaison to this committee. I want to make sure everyone understands how important this is to the Oregon Health Policy Board. And I know it's, of course, important to all of you and actually to all of Oregonians. Cost growth has been a problem for many patients, for consumers in general, for employers, large and small. It's also a challenge. I worked in the healthcare industry for many, many years, and it's hard to figure out how to be efficient, how to deliver appropriate care, and how to deliver a high value. So we recognize that while this is a significant challenge, but that work needs to be done that can benefit all Oregonians. And that's why it's one of the top priorities for the Oregon Health Policy Board. We have 4 explicit priorities, and supporting the work of this Cost Growth Target Committee is one of those. Second point I want to make is that there's been a tremendous amount of work done leading up to this to ensure that the committee would be representative of all the stakeholders involved in this, both the ones who are paying the bills, patients and employers, those who are involved in the work of improving efficiency and improving quality and value, physician groups, hospitals, health plans, but also ensuring appropriate geographic representation and other dimensions demographic, and so on, to ensure that we have a diverse and representative group. That I think is going to be one of the strengths of this committee going forward, and I'm very pleased at the outcome of that work. But I will say it took a lot of work, and Sarah Barham deserves a lot of credit for the work she did to recruit and put together this group. Finally, I'll just say that while the focus of our work here is cost growth, cost growth does not stand by itself as an issue in healthcare. And I see this as not just a cost issue, but also an equity issue. Equity is one of the other priorities of the Oregon Health Policy Board, and I see these being closely intertwined. We know that high costs hit different groups in different ways, and addressing the cost problem will also help us address the equity issues, reduce disparities that exist in our system. So I appreciate your willingness to participate in this. I applaud your eagerness to take on this challenging work, and I look forward to providing support to the work as this goes forward.
Thanks, Bill. Jeremy, anything else you'd like to add?
No, I guess one last thing I would just say is, Sarah has done an incredible job. We have now a team leading this work, and they're here to support you as well. So we've got a lot of resources. We've got a lot of data and analytics work that's happening that you'll be hearing about, and know that we're here to support you all as you go on this difficult journey with this as well.
Quickly, thanks everyone for being here, and just to reemphasize again the importance of this work for everything that we've done and every lever that we've tried over now decades in Oregon. I think costs continue to be the challenge, and if we don't do anything, we ultimately spend all of our money on healthcare, and much as we love our friends and partners in the healthcare industry, that's not sustainable. And so I'm really encouraged by the fact that a number of states are heading down this path, try to work.
All the work ahead of us. This is a great endeavor and an example for other states. So glad to be participating in it, and I look forward to our work. Thanks.
Great, thank you both. Okay, we are going to move to our first presentation. So Durandi, next slide, 2 slides actually, and I'm going to introduce Michael. So Michael Baylett is the president and founder of Baylett Health. His work focuses on how purchasers and regulators can influence healthcare markets to operate as effectively and efficiently as possible. So that includes payment strategy design, performance measurement, value-based purchasing, and of course, cost growth target work. So Michael has a long history working with us in Oregon. He's been with our cost growth target program from the beginning. He helped shape and develop the cost growth target implementation committee and recommendations. And he is continuing to provide technical assistance to the cost growth target states through the Peterson-Milbank program for sustainable healthcare costs. So Michael, I know you are familiar to many of our committee members, but not all. So welcome, and we're excited to have you with us for this phase of the work.
Thank you, Sarah. And hi, everybody. It's nice to be with you this afternoon. I'm going to give you a little bit of a high-level view of cost growth target activity in the United States. I'm going to focus on a couple of states for examples. I want to invite you to ask questions as I go along, should anything that I share prompt you to do so. Durandi, next slide, please. So I'm going to cover 2 things. Number one is probably something that Sarah covered in your orientation, but I think I think understanding the what's and whys of cost growth targets is really important. So I'm going to come back to that topic. And then I'm going to look at Massachusetts experience. The reason I'm looking at Massachusetts is because Massachusetts implemented its cost growth target program in 2013, a full 5 years before any other state did, actually 6 years before any other state did so. And so it has the most experience, and thus it's interesting to look at. And then I'm going to give you a case study of the use of cost growth driver analysis to support affordability work that is all around a cost growth target. So that's the plan. Next slide, please. So I'm going to start with cost growth targets as a cost containment, or really a cost growth containment strategy, and the whys and wherefores. Next slide, please. So for simple definitional purposes, a cost growth target is an expectation for how much healthcare spending should grow. Just coincidentally, I just read a letter that Don Berwick wrote. Don is sort of a luminary in the United States in terms of health policy and quality improvement. He's a former CMS administrator, and he sits on the Massachusetts Health Policy Commission. And he wrote a letter because he missed a recent meeting, and he wrote, "The target is not a prediction, it's a prescription." And I think that neatly summarizes what a cost growth target is, a prescription. And not a prediction, because if we created a prediction, it would be for rates far above what we would put in a prescription. So the reason why this, and Jeremy in many presentations has shared this, on the next slide, please. Our fundamental problem is that for year after year after year after year, healthcare expenditures exceed wage growth, and in most years, they exceed economic growth. And so that wage growth differential just hammers households across the United States, because it means that they've got less money for housing, less money for education, less money for food, less money for everything else for which they have need. And every year, healthcare spending is taking away chunks and chunks of take-home pay. So that's the fundamental problem. And despite many, many years, going frankly much further back than 2010, of all sorts of efforts to slow healthcare spending, none of it's worked. If you could advance, Charlie. I've got a little animation in here. So they're doing this because nothing else has worked. So time for something new. So next slide has a map of the other states. Jeremy was referencing other states. Jeremy, the answer is there are 8 states now. They are all in blue here. Oregon was the 4th. There are 4 states that have followed, and the states that are in orange, California, Minnesota, and Vermont, are now considering doing the same. So I think it's fair to say that there's something of a movement underway, and as in most policy innovations, the work often starts at the coast, and we've seen that here. What this means, though, is that there's an opportunity for Oregon to learn from other states and for other states to learn from Oregon. And in fact, that type of learning is happening. Sarah and colleagues were in a meeting in DC just a couple weeks ago, where there was all sorts of cross-state learning going on in a really exciting way. So why did all these states do this? Well, it's all primarily for the reason represented on the last graph, but they all pointed to slightly different things. Next slide, please. So in Massachusetts, there's a famous graph that shows growth in spending for state purchased healthcare over a dozen years, and then what was happening on state spending for all sorts of other services that would be considered to be of value to taxpayers. And you could see in the graph, spending was going down as a percentage of total state spending for every category except for state purchased healthcare. And so you could literally see healthcare pulling money out of other state spending. I talked earlier about consumers and take-home pay, but this is also an issue at the employer and state level, where money for healthcare spending is pulling money from other worthwhile purposes. In Delaware, they pointed to the fact that their per capita spending was third highest in the nation. In Rhode Island, they pointed to health insurance filings exceeding wage growth in most cases. And in Connecticut, it was healthcare spending outpacing state economic growth and taking up a larger portion of state GDP. So all for economic reasons, but they all pointed to something a little bit different when they decided to do it. Now, the next slide lays out the logic model for a cost growth target. I'm guessing that you've seen this before, but I think this is so important that I want to spend a little time on it. So I've used all sorts of analogies for what a cost growth target is. I've talked about it as an anchor. Sometimes I think about it as a fulcrum. Sometimes it's a spotlight. But clearly, it sits in the middle of a strategy to improve healthcare affordability or to make increases in spending at least more affordable, if not to get to overall affordability. But in and of itself, it is grossly insufficient. And so it has to be complemented by other strategies. And that's what this logic model is here before you. So let me explain to you the elements, why I think they're important. So starting with the mustard colored scales in the top right, there's measurement of performance relative to the cost growth target. And has the state been successful in constraining healthcare spending growth? And I say the state, but it's not the state. It's provider organizations, payers, state policymakers, employers. It's all of those actors working together. And have they collectively been effective in restraining cost growth on an annual basis, year after year after year, to come in at whatever the cost growth target value happens to be for that year? So that's a starting point. The measurement that's done to assess performance against the cost growth target uses aggregate data from payers. That aggregate data doesn't really give a nuanced understanding in terms of where and why healthcare spending is growing. And so there needs to be a complementary set of analyses, which is that orange circle, to understand what's driving healthcare spending and what's driving healthcare spending growth, which are not necessarily the same thing. And that type of analysis is done by states using claims data. Most of the cost growth target states have all payer claims databases. In Oregon, that's referred to as APAC, and they mine that information to get a much more nuanced understanding of what's happening in healthcare spending. And the Connecticut example I'm going to share a little bit is just one limited case study of doing that type of analysis and being able to answer questions about what's really driving healthcare spending and how does it vary by geography, by market, by population, other important ways of understanding. Third is publishing to the public analysis that reveals performance against the target at the state level, at the payer level, and at the large provider organization level, in addition to the state. And also publishing analysis that makes clear to everyone, here's what's driving healthcare spending growth in our state. And the answers are not identical in every state, although I will say there are certainly themes that run across states based on data that we've looked at for multiple states. It's really important to put that information out in front of the public so that there is common understanding and that we can name our problems, because we can't solve our problems if we can't name them. And so that's why this public reporting of the analyses is important. It doesn't mean putting out gross amounts of data for people to wade into. It means analyzing and summarizing and making information available in a way that's accessible and that helps people with diagnosis, because with diagnosis, we then can act. And that takes me to the next circle, the blue one. With that public reporting, we want to identify where there are opportunities to slow spending growth and what are potential strategies for doing so. And then finally, we close this loop and the logic model by implementing strategies. This is a series of ongoing iterative activities year over year. The cost growth target sets an objective, or a prescription, as Don Berwick says, but all these other activities is what moves us to affordability. So let me pause Anybody have any questions or comments on this or anything else that I've shared so far? Okay, let me share with you now the experience of Massachusetts. As I said, it's the state that did this first, and so we have the most data from Massachusetts. Next slide, please. Actually, 2 slides. Okay, so Massachusetts established its cost growth target by a statute in 2012. That means that it became effective for measurement purposes in 2013. They initially set their target, which they call a benchmark, at 3.6%. It dropped to 3.1% in 2018. So you can see that for 2013 through 2017, they were significantly below for 3 of 5 years. For one of the years that they exceeded, it was due to the introduction of medication to treat hepatitis C. So there was a big spike in spending, which everyone thought was a good spike in spending. But in the years that followed, 2018 and 2019, they jumped up above their cost growth target as the cost growth target value came down to 3.1%. And that generated some concern and has generated some new policy action in the state. Because I think there's concern that as of 2018 and 2019, that the state's existing tools that they were applying to improve affordable healthcare spending growth weren't working anymore. And then you see in 2020, there's that negative trend. And that clearly is an artifact of COVID-19 and almost the complete cessation of people accessing healthcare outside of for COVID in those early months of 2020, and then depressed utilizations the rest of the year. This trend I've seen in every state. Every state that at least every cost growth target state that's reported data has reported negative all-payer trend in 2020. So the next couple of slides have information on Massachusetts performance relative to national benchmarks. Next slide, please. So this looks at total healthcare spending growth in Massachusetts. And I'll note a couple things here. One is the Massachusetts all-payer trend has generally been below, although not every single year, a couple of years just at the national average. But that trend actually began in 2010, which was 3 years before their cost growth target became effective. You can see that in the prior years, 2009 earlier, Massachusetts was above, sometimes way above. So it's not clear that this is all causal, since the drop below the national began before they implemented their cost growth target program. But certainly they've stayed below the national average, although certainly increasing every year. What's a little bit more interesting is to focus on the commercial market. And the reason we want to focus on the commercial market is because Medicare and state Medicaid programs have a fair amount of influence over healthcare spending growth. There is not the same amount of what I'll call budget discipline in the commercial market, where individual commercial payers cannot bring the same leverage to bear that a state Medicaid agency can, or certainly that CMS can for Medicare. So if we would expect to see a state healthcare cost growth target have impact most, we would expect to see it in the commercial market, because that's where per capita trend tends to be highest. So the next slide looks at what happened on commercial trend in Massachusetts relative to the US. And here we can see certainly a strong correlation between the implementation of their cost growth target in 2013 and spending growth that has been positive, but pretty significantly below the US rate by 1 or 2 percentage points for several of these years. So this suggests, at least to me, that the cost growth target in Massachusetts has been effective in slowing commercial market healthcare spending growth, which is where we would expect to see an impact if there is going to be an impact. Any questions or reactions to either of these two slides? Okay, let's go to the next slide. I'm going to share with you why I think Massachusetts may have been successful so far. And I want to note that every state's dynamics are different in so many ways. And so what the reason that a policy might have worked in Massachusetts is not necessarily a reason that's going to work in Oregon or Delaware or Washington or Nevada or anyplace else. But in Massachusetts, the way I think it worked is the cost growth target was a highly, highly visible policy initiative that was abundantly clear to all major payers and to large provider organizations in the state. Everybody knew what it was. We didn't have the problem, or they didn't have the problem, of payers and providers not knowing what the target was. Two, Massachusetts had at the time of implementation of the policy widespread use of total cost of care contracting. And a cost growth target translates very easily and very directly to the terms by which total cost of care contracts occur, because those terms usually have per capita growth in the budgets that are included within the contracts. So it was very easy to translate the cost growth target into the payment model. And in fact, that's what happened. So in speaking with payers and providers within the state, what we've learned is that the payers, when it was time to negotiate the contract, said, okay, the starting point for negotiations is the cost growth target. And there was understanding on the part of provider organizations that that would be the starting point for negotiations. That provided payers with an impressive tool to use. But I also have to say the provider organizations also were accepting and buying into the cost growth target. Either happily or unhappily, I can't say, but they were willing and did negotiate around the cost growth target, or again, what they call the benchmark in Massachusetts. And then finally, the state was transparent in performance against the cost growth target, and they reported how payers and large provider organizations performed relative to the target. And that obviously was going to help increase a sense of accountability. All right, so this is my take on why I think that this has been successful so far in Massachusetts. So next slide, please. So Massachusetts has one consequence right now for payers or provider organizations that do not achieve the target, and that is they can require a performance improvement plan. I will note that Oregon has the same provision. Massachusetts did not apply this provision, however, until 2022. And I think it's arguable about whether that was the right decision or not. And certainly it's interesting to understand why they didn't do so. But they did do so for the first time this year. I will say that in the intervening years, it's not that they were silent when there was a provider or payer organization that was exceeding the target. They in fact had lots of meetings and conversations with those organizations, but they didn't formally require performance improvement plan until this year. And they did so for Mass General Brigham, which is the state's largest healthcare system. So I'll share a little bit of information about this and how that's worked. Next slide, please. So the state reported that Mass General Brigham's commercial contracts were above the target cumulatively for $293 million between 2014 and 2019. And that this was far more than any other provider or health system. They also noted that even in total cost of care value-based contracts, that rates were also above the cost growth target. So clearly the payers were not successful in those cases in negotiating contracts with Mass General Brigham at the cost growth target. And that probably speaks to the market power that Mass General Brigham has in the state. The state also reported that prices for both hospital services and physician prices were much higher for Mass General Brigham than for nearly all other providers in the state. And then finally, they showed that healthcare spending growth was not due to utilization, but due to increases in prices and increased intensity of service mix. So Mass General Brigham had to respond. They did. Next slide, please. So they submitted a proposal to the state to reduce spending by $70 million by 18 months from now. And their proposal had 4 elements, which you see listed here. Most of these are about finding ways to reduce spending by changing utilization patterns. But there was one proposal to reduce prices and price variation in hospital outpatient rates. So will the Health Policy Commission accept this plan? We don't know yet. So I would say stay tuned, but this is the first application of this strategy ever in the state. Any questions about anything regarding Massachusetts?
Yeah, this is Nick Powers. Thank you for this presentation. Just curious, you mentioned market power, and I'm curious if Massachusetts has learned anything about consolidation in the industry and how it affects costs.
Yeah, so I'm going to share some information from Connecticut on this, Nick, shortly. The research literature is overwhelmingly clear that market consolidation amasses market power and drives up prices. I would say that is well, I guess anyone could argue any point, but I would say it's a non-controversial finding.
Okay, great. Thank you. I assumed that data existed, but it's good to hear that.
Yeah, it does exist. Pat?
I should know this, but does Mass General Brigham have an integrated health insurance carrier, or is it standalone healthcare provider?
So they did buy a nonprofit health plan. It was a Medicaid health plan, and they converted it into a commercial plan and got out of the Medicaid business. It was actually a Medicaid health plan created by FQHCs, which is, a little ironic. It doesn't have a lot of market share, though. It's primarily serving their employees and dependents at this point.
Got it. Thank you.
Yeah. Mary Beth?
I was thinking about the graphs that you had shown earlier a little bit more. And does Massachusetts also break out the measurements by providers versus carriers and have that data?
They do.
Okay,
I
I was
will
curious
say-
to see if that had an effect or if they measured by sector for that.
Yeah, they do. I would say that compared to some other cost growth target states that are participating in the Peterson-Milbank program, Massachusetts has not been aggressive with its transparency. There are other states that have named names in a little more forthright manner than Massachusetts has. You have to look a little bit to find the data from Massachusetts, whereas other states haven't made you look. Alyssa?
Just maybe 2 questions. One is on the utilization component. You said that actually didn't decline, so it was a pricing. So I don't know how Oregon compares on the utilization side compared to Massachusetts. That's one question. Then over the time, did they see medical debt go down, or the per capita medical debt?
So I don't know if they've measured it. I mean, I will note Massachusetts was not successful in reducing healthcare spending. All they did was slow the rate of growth by 1% or 2%.
Right.
But I don't know if they've done that assessment. And let me clarify, on utilization, what they were measuring was what was contributing to spending growth, not absolute utilization. So if you want to do a comparison to Oregon, there are 2 comparisons you can do. What does overall utilization level look like? And then how much is utilization growing or declining over time? But those are 2 different assessments. Jim?
Thank you. And so following somewhat on Mary Beth's question, and so that I stay focused on our target. It appears that the cost growths we're measuring are from the providers and not carrier cost growths or disparities. Is that correct?
So, so the data that's collected for measurement, Jim, comes from two sources. When you're measuring cost growth target data performance, cost growth target performance, you're collecting aggregate data that is for what's called allowed spending. So it includes both what the payer received, what the provider received from the payer, and what the consumer was responsible for out of pocket. Then separately, there's analysis of claims data that the state can do using APAC. And using that information, it's actually possible to tease out how much was consumer out-of-pocket spending growing versus total spending. Okay, but you can only do that analysis with the claims data in APAC. And some other states have done that. Michael, then Gil, then I'm going to move on to the next topic.
Sure, and if my question is better answered later, just let me know. I'm just curious if they did any kind of health equity impact analysis, right, or looked at kind of impacts, disparities with some of the strategies that they implemented to do this.
Yeah, great question. I don't know if they've done so. They might have, I don't know. I can tell you from working with other states that there are some other states that when they created their cost growth target, they created and sort of an equity analysis plan so they could assess for adverse impact that could result from the cost growth target. Although there was no sense that it was going to create an adverse impact, but they felt there was a responsibility to. So they developed a whole set of measures to look at. I will also share that I know of other states that have looked at healthcare spending and utilization patterns stratified by income and race using data available to them. So that's certainly a possibility. And one did some really interesting analysis to understand what appeared to be disparities in ED utilization by race. And by digging down further and further, it was actually able to explain away the disparities, but it took some work. Gil.
Yeah, similar to the last question, just wondering about more of a quadruple aim approach, you know, where they're looking at, or was there any attempt to correlate quality outcomes, you know, with variations in costs?
Yeah, so it's a great question. All of these states started this work saying we need to prioritize affordability. Most of them had been doing something on quality, but really had made no headway in affordability. And so that was their principal focus. How do we focus on affordability? There are, though, some states that have said, you know what, we want to lift up quality and equity on equal footing with affordability and look at them in parallel. So there are a couple states that have quality targets that are to be used in parallel with their cost growth targets. I would say most of the states are not doing that. They're still, you know, focusing on affordability, feeling like it's a priority problem that has never received sufficient attention. But there are some states that are trying to balance multiple objectives through the one initiative.
And Michael, can I add that having a quality and equity strategy or looking at some of those things and monitoring for negative impacts is one of the charges for the Oregon program. And that's something that we expect to bring back to the advisory committee to continue developing. We have some starting places from the implementation committee, but it's not fully fleshed out, and it's likely something that the advisory committee will pick up next year.
Thanks, Sarah. Okay, Drondi, could we go to the next 2 slides ahead? So I'm going to share with you some information about Connecticut. This is just a case example, and it's not even showing all of their work, but it's an example of a state mining its all payer claims database, or APCD. And they actually did so before they even did their first baseline year of measurement relative to their cost growth target. They had an analytics contractor, and they had them look at patterns of spending growth over multiple years, 2015 to 2019. And they focused initially on the commercial market because that's where they had complete data available, whereas they didn't for Medicaid and Medicare. You advance, please. So they focus especially on understanding the distinct roles of price growth and volume growth to understand what was driving spending. And what I'm going to share with you was first presented to their stakeholder steering committee last fall. Next slide. So this is literally a slide that they presented, and they found that their per capita trend was 5.3% on average between 2015 and 2019 in the commercial market. Their wage growth during this time period was 2.6%. So commercial healthcare spending was double what wage growth was. And you can see the services are broken down to broad categories. See here in the maroon boldface font that it was clear that it was hospital spending and pharmacy spending, and this is retail pharmacy spending, that was driving their spending growth. The largest category of spending in 2019 was professional, but professional spending was growing only 2.7% a year on average. So this allowed them to isolate where spending was happening fastest. Next slide, please. So then they broke down what was happening in these services between, and pharmacy is not on this slide, I want to note, between spending per unit, which is what we really mean, not price, spending per unit, and volume. And over in the right column, you can see what was happening in volume. Inpatient utilization down 10% in 4 years, hospital outpatient down 2.5%, professional up a little bit at 2%. So it wasn't about volume. It was about annual increases in spending per unit of service. And the increases were just enormous, as you can see here. So again, think back, wages were growing 2.6%. But the payment for an inpatient stay grew 9.3% in 2019, 8.3% for an outpatient. I will say, although it's not listed here, that the finding for retail pharmacy was the same. It was all about increases in spending per unit. Pharmacy utilization actually was declining on a per capita basis. Next slide, please. A couple of other interesting things. In a very concentrated market, 2 systems represented 57% of their discharges and 4 systems represented 76%. Discharge volume dropped across all the hospitals, but there was a lot of variation between hospitals. Another interesting finding is on the next slide. So they looked at where rates of payment per unit of service were growing. And so this was an analysis of the 10 hospitals with the highest rates of growth in payment per case mix adjusted discharge. Of the 10 hospitals, 5 of them had the highest cost per case mix adjusted discharge, and 4 of the 5 were affiliated with their largest systems. Of the 10 with the lowest rates of growth, 5 of them also had the absolute lowest cost per case mix adjusted discharge, and 4 of the 5 were unaffiliated with the largest systems. So this suggests that those that were affiliated with large systems had high payment rates that grew at the fastest rates. And those that were unaffiliated had lower rates and they grew at lower rates. Okay, I say this suggests because this is not as complete an analysis as you might like to see. Okay, but certainly they did other analyses that found relationships between system affiliation and rates of growth and baseline rates and rates of growth. And there were correlations. Next slide. So a steering committee member asked for additional information. He asked 2 questions. What's behind hospital price growth and is cost shifting occurring? Well, there were probably 12 slides of content that we provided a subsequent meeting, but in short, and I mean very short, The answer to what's behind hospital price growth is nationally, it's market power, and there is study after study after study that shows this in terms of what's driving commercial hospital price growth. And the question of cost shifting, research finds that hospitals don't cost shift, meaning they don't say, well, because I'm getting less from a public payer, I'm going to charge more to a higher payer. Rather, research shows that they engage in price discrimination, which means they charge more to customers with whom they are able to charge more, which happens in all markets, not just in the hospital market. And we looked at specific data in Connecticut to assess cost shifting, because if cost shifting exists, it means that hospitals that are more dependent on public payers that pay not as well compared to private payers would be expected to have their commercial rates grow faster because they're more dependent on public payers. We found just the opposite. So the hospitals in Connecticut that were greater than 50% private pay had significantly higher rates of payment growth than hospitals that were primarily dependent on public payers. They had much slower rates of growth in commercial rates, which again, I think speaks to market power. Okay, so these are the types of conversations they had, the types of analyses they looked at. Why don't I go on and share a little bit more data with you, and then I'll wrap up. Next slide, please. So they've shared all of this information from their APCD analysis and much, much more data in all sorts of forums. You can see them listed here many times, many ways. Joanna, could you advance a little further? They've also shared them directly with the two large hospital systems and with the most expensive independent hospital, and showed them how their individual hospitals perform relative to one another and to statewide medians. And once further, and they're planning on making all of the hospital-specific data public shortly. Next slide. So this is an example of hospital-specific information. I blinded the name of the hospital, but this is a hospital system. We've listed hospitals A, B, and C there. So they saw, this is for their inpatient payments, how much the payments grew per case mix adjusted discharge, and then unadjusted. Because of time constraints, I'm not going to explain why we showed it both ways, but maybe at a future meeting, we can talk about why both methods were shared. You can see there are big differences, whether it's case mix adjusted or not. Next slide. This is an example for outpatient services. This is for radiology, payments per service unit, and again, the same types of comparisons. Okay, and next slide. So finally, I want to share with you the data that was shared from the cost growth target baseline analysis. So this is the aggregate data that came from the payers, not the data that came from the all payer claims database. This chart depicts the contribution to commercial spending growth in 2019. And the size of the bubble indicates what made the largest contribution. So you can see here, it was hospital outpatient and hospital inpatient with the two largest bubbles, okay? 7% growth for outpatient, 9% growth for inpatient, the biggest contributor to trend, okay? This particular year, retail pharmacy did not have a big contribution. What we found is retail pharmacy can grow tremendously one year and then modestly the next year. It's highly volatile because of the introduction of new drugs and drugs going off patent. Next slide. So in summary, by using transparency of data analysis, Connecticut has, in my words, primed the pump for future policy action. And it says state policy action. It doesn't necessarily mean it's by the state, although it might be. But it certainly creates an opportunity for conversation among stakeholders about what's driving spending and what could Connecticut as a state in partnership with its stakeholders do to slow hospital spending growth and pharmacy spending growth as contributors. And there's a whole bunch of pharmacy analyses that I haven't shared with you, but that they performed. Next, please. So as I've said, they've engaged all sorts of stakeholders and elevated this topic for discussion. Next. So a few lessons learned. First is a cost growth target can be effective in bringing attention to healthcare spending growth and transparency about where it's growing, for whom it's growing, and what's causing it. Two, measuring and reporting performance against the cost growth target isn't enough to generate sustained improvement in affordability. There have to be policy initiatives implemented to address the cost drivers. Three, states need to perform and publicly report on analyses that drill down into cost drivers to give insight, and then need to prioritize and implement policy initiatives that will address the cost drivers. And finally, just to be honest, this is really hard work. It requires strong will, partnership, and a lot of perseverance. And the fact that it's hard is shown by those graphs early on that shows year after year after year spending exceeding wage growth. And so I just want to acknowledge that none of this is easy. And with that, I think I'll come to a close.
And before we open it up, I know we have hands, Lawrence and then Melissa to start, but I just want to let the advisory committee know that sharing this type of data and these type of analyses, that is in the works for Oregon. And we plan on bringing some similar data to you beginning in July. I also want to put in a plug for Oregon's hospital reporting program, which has a new annual publication coming out in just a couple of weeks, and we'll have a lot of detailed hospital data available. So I think I want to just caution us all to not interpret the Massachusetts or the Connecticut specific findings as the exact cost drivers or problems for Oregon. We need to look at our own data and dig in and really understand our own cost drivers. So I think everything Michael shared, it's great in setting examples and case studies for how we should look at that. But I would caution us to not jump right into, well, maybe that's not the problem here, because we will look at our own data in coming meetings.
Right, your own data should tell you what you need to focus upon. And fortunately, you have that resource, so it will allow you to do so. Okay, I can take a couple of questions and then I have a conflict, so I need to go. So Lawrence?
Thank you, Michael. That was really, really helpful. I wonder if I could share, this is more a comment, but a perspective from OHSU, which is the Academic Health Center here in Oregon, on data I publish, report publicly to our board and publish on the web every quarter. If you look at our patient activity, it's half inpatient but half outpatient, and moving to outpatient at a point a year, and it's half government and half private in terms of net revenues. If you look at the total payments to OHSU per case mix and outpatient adjusted admission, so a aggregate look at what there was a subset of a look on your page 29, it grows pretty consistently at only 2% a year. And our wage growth grows at 3.5% a year pre-pandemic and much faster than that now. So the comment I just wanted to make is that from the perspective of one provider at least, and again, I'd be very happy to share this data all publicly with this committee, we actually have the reverse of what you're talking about here, which is aggregate payment rate growth that is substantially below aggregate wage and cost inflation, causing us to have a gap of about $60 million a year we have to close, and then the next year another 60 million, and a third year a third 60 million. So I think it's important to look not only at the specific drivers you've looked at in these examples, but on how the aggregate picture of all the pieces fit together.
Yeah, absolutely. I mean, I think this should all be data driven. And one state's story is not necessarily your story, but use the rich data that you have to understand what's happening in Oregon. Greg?
Thanks, Michael. I was just wondering, you provided the example in Massachusetts of the performance improvement plans being implemented for entities that did not meet the cost growth target. I was wondering if there are any examples or even like conversations about incentives that could be built that incentivize coming in below the cost growth target in a particular year. Is that something that's been discussed?
So Massachusetts is talking right now about what else they have to do. I think at least the staff and members of the Health Policy Commission believe that their performance improvement plan is insufficient. So they have approached the legislature about giving them additional tools. That may or may not come out of this legislative session, which still has not closed in Massachusetts. They've got about a week to go. So we'll see what happens, but they are considering doing other things.
And Greg, I would add specifically for Oregon, we're having some individual conversations with provider organizations this summer. And I think this question of, is this just a carrot or is this just a stick, or is there also a carrot for the program, has come up in a couple of conversations already. And I think that might be a good conversation for the advisory committee to have in the future. I think we're a little bit too early to say that stick only is problematic or performance improvement plan and financial penalties are insufficient and we need something more incentivizing. But I think that's something that's well within the scope for future committee discussions.
Great, thank you both.
Yeah, and Greg, there really aren't lessons to learn from other states at this point. So this might be a place where you all have to innovate a little.
Melissa and Felisa both had hands up at some point. Are there still questions or comments there?
Yeah, this is Melissa. Just a couple more comments. I think, Michael, appreciate the presentation. And I know, Sarah, I've heard from you that we'll go over data specific to Oregon, because I think not including the pharmaceutical expense and that component of that is really important, right? And then I know, just noting on your slides that none of it's risk adjusted. And so it's hard to understand the kind of cost growth, but if the community is getting sicker, not that, I mean, our whole goal is that our community gets healthier, but if the community is getting sicker or aging, that's not well understood without that risk adjustment and what's driving that.
So I would encourage for a future meeting that you all do a deep dive into risk adjustment. It is a complex and somewhat controversial topic, and it's really important. So I just suggest that for the future. And I want to be clear, I think in doing this work, there shouldn't be any finger pointing, but there also has to be honesty when looking at the data to say, so what's it telling us? All right, Gil, and then I really have to go.
Yeah, just a quick question. I'm wondering if in any of your studies, you had looked at any international examples to help guide some strategies around cost containment?
No, to be honest.
I'm just wondering, because the US is like way higher in cost GDP, percent GDP, and our outcomes are not so great.
Right. Research shows that it's basically because the prices that we pay are just so far beyond what anybody else pays.
All right, Michael, I know you have to go. We have a couple more comments or questions from Felisa and Stefan. So let's get those in the queue and we will follow up with Michael over email if needed to get a response.
Yeah, and I apologize that I have to leave early today. I will be here for the duration of future meetings. And I look forward to working with all.
Okay, Felisa.
I think this is I'm a little confused, but I think a time for future requests. So I hear the workforce costs, and I think that has been very true over the last year. So it would be good. I think that there is an analysis, Sarah, coming up on that, and the data collection coming up on that, because I think it would be good to sort of see where those workforce costs are and which workforce is driving those cost increases.
Yep, that is a hot topic coming up in all of our payer and provider conversations this year. Stefan.
Yes, this is a comment that's perhaps future agenda, but I just wanted to say there's a little bit of a sort of like a puzzle here. You know, it's like between high costs on one hand and you know, precarious financial health for a lot of hospitals. And I wonder whether you know, that's something that you have looked into or you could comment on, or maybe it's something for a future discussion.
I think I want to put a pin in that for future discussion. I think one of the things that we're hoping to do with this committee over and over again is start bringing you data and then digging into those weeds and having those discussions to look at the cost drivers on some of those trade-offs and balances. I think the workforce issue, the operating costs, the payments, the price versus the utilization, the effective risk adjustment. I think all of those are things that we would like to have a really data-driven conversation about starting at our next meeting. Okay, I am going to keep us moving. We are running a few minutes behind schedule. So what we were going to do next was just provide a couple of reframing slides. Hopefully everyone remembers this from the orientation. I'm going to run through this really fast and then we're going to go to introductions. So Geraldine, next slide. Michael talked about this in detail, so next slide. Just to remind everybody, Oregon does have the cost growth target set for the next 10 years. For 21 to 25, it is set at 3.4%. For 26 to 2030, it is set at 3.0%. So all of our talk of relative to the cost growth target is relative to those two numbers. You as the advisory committee will be revisiting whether or not 3.0% is still appropriate for 2026. We will come back to that in a future conversation, not this year, but in the future, that will be an advisory committee charge. So just know that our intent, unlike some of the other states where they set their cost growth target or benchmark every year, we intended it to be set for several years in advance so that there was stability and predictability for all of the entities working to meet the cost growth target. Next. The cost growth target applies at 4 levels. We will be measuring and reporting at all of these levels. So beginning at our July meeting, we'll bring some data forward that talks about cost growth trends historically at the statewide and at the market level. And when we're talking about market, we mean Medicaid, Medicare, and commercial. In future years, we'll begin publicly reporting identified data at the insurer and at the provider level, so large provider organizations. We're currently vetting the initial data with payers and providers right now, but we've said that that initial data collection would not be publicly reported, so that's coming next year. Next. I'm going to skip this next. And one more skip. Michael talked about this a little bit, but just to remind everyone, our program does phase in over time. So we have been collecting initial data, looking at cost growth between 18, 19, and 20. We're not publicly reporting that data. There are no accountability measures in that time period. In September, we will collect the next round of data that's looking at cost growth between 2020 and 2021. We'll collect and validate that data in the fall. We'll publicly report it ideally by the end of the year, probably early next year. That will be publicly identified by payer and providers. Performance improvement plans and financial penalties still do not apply. That's phased in a little bit later. So again, just knowing that there's still a pretty long on-ramp that the implementation committee designed for all of the mechanisms of the program to be in effect. And next. And finally, just to check and maybe a little bit of comparison to the other states. So I think as we're hearing about Connecticut and Massachusetts and some of the other states, Oregon's cost growth target program is really broad in its inclusion. We collected data from 32 different data submitters this year. Some of the other states are in the ballpark of 5 to 10 data submitters. And we are validating with 50 provider organizations this summer. So other states have about 8 or 10 provider organizations. So our scale and scope of who's included in this program is a lot broader, and our market is less consolidated. And that just means we have more conversations and more nuance to bring to the data as we go through this process. We are currently meeting with those 50 provider organizations this summer to discuss that initial data. And after the validation is complete and we've gone through that process, we will be producing a baseline report looking at that 2018, 19, and 20 measurement period. And we'll be bringing that back to you as the committee. So just a quick check-in on where we are in the process, and we'll be talking more about the data in all of our future meetings. Any questions about any of that real quick? Intro and overview? Okay, great. Let's stop with all of our intro comments then and go to introductions. So again, I'm sorry we did this out of order, but we really wanted to make sure Michael could present before he had to leave and we were juggling time zones. So we are going to ask you all to introduce yourselves. We have a couple of things that we'd like you to share in your introductions. We'd like you to share your name, your pronouns, your organization, your role or your title, and one thing that excites you about this work or about being part of this committee. What's something you're looking forward to or particularly interested in digging in?
Nana, you put your violin by the door. You have practice with Lillian today.
And we are going to do some.
Put your violin by your door.
Thank you. Okay. I'm going to call on people as I see them across my screen. So in no particular order, if you are okay introducing yourself and sharing. I know that you did this in our smaller orientation meetings, but now we're bringing everyone together and some of you have not yet met. So let's go ahead and get started. Jim, would you like to start, please?
Remembering to unmute. Thank you, Sarah. Jim Hauser, he, him, recently retired auto mechanic and 37-year auto shop owner in Southeast Portland. What is it? Where my I guess small business owners I know are about evenly divided on whether the government isn't doing enough on healthcare and those who've totally given up that healthcare costs are going to be controlled. And so I see my role as communicating the measures that we're taking, the concrete steps we're taking to try to control these healthcare prices, and hoping to build some optimism among small business owners on this issue. And I don't know how successful I will be at that. But the problem I see is communication. I mean, we can count on the media in July to say how much the premiums are going to go up, and that's about all we're going to see in the typical media. So I think that's our biggest challenge, is to let people know. Thank you.
Thanks, Jim. Melissa.
Hi, Melissa Dom, she, her. I'm with Providence. I'm the CFO for the delivery system here. I'm a native Oregonian, and you know, really excited to be a part of this group and help be a part of the discussion, understand the complexity of the delivery of healthcare. Help this group understand and problem solve around how our hospitals service safety nets and are often providing care that's not health or medical, but a part of that equation on the expense side. And looking forward, you know, our motto here is around creating healthier communities together, and that really is the intent and the focus of this group overall, both physical wellness and financial wellness. I think it's a part of that. So thank you.
Thank you. Felisa.
Hi, I'm Felisa Higgins. I'm the political director at SEIU Local 49. My pronouns are she, her, they, them. I think I'm most excited about this work progressing beyond Medicaid and Medicare when it comes to cost and really leaning into the commercial market. And I see many of our members who have had multiple challenges over their lives or have had their lives destroyed because of medical debt. And I know that many families are, you know, one accident, one fall, one break, et cetera, away from a devastating incident in their lives. And so I'm looking forward to just continuing the work that Oregon's been doing to sort of stop that.
Thank you. Stefan.
Hello, I'm Stefan Lindner. I hope you can hear me. Yes. My computer is kind of overheating, so it's a little bit delayed, everything. My name is Stefan Lindner. My pronouns are he, him, his. I'm a research assistant professor at OHSU. My background is that of an economist. A lot of my work is on healthcare reform, specifically public health, specifically Medicaid. I do a lot of work with Medicaid claims data. I'm excited about, as you might expect from that description, about some of the technical data issues that we'll encounter. And I'm also excited about some of the economic challenges that already surfaced, and I think that will continue to surface during this committee.
Thank you. Shannon.
Hi, thank you. I'm Shannon Saldivar. I own Saldivar Insurance here in the Dalles, Oregon. I use she, her pronouns. I'm most excited about the data and understanding some of the drivers and hopefully being a little bit of the perspective from the consumer. We work with a lot of consumers on the ground, enrolling them in health insurance, and get to also see what an impact the cost of healthcare has on those consumers. So I appreciate the opportunity to be here. Thank you.
Thank you. Lawrence.
Hi, everyone. I'm Lawrence Frenstall. I'm Executive Vice President and University CFO at OHSU. I use he, him, his pronouns, and I'm excited to participate in a view of the issue of healthcare spending from all of its perspectives and all of its complexities. So I very much appreciate the breadth of this group and all the experiences you all bring.
Thank you. Greg.
Hi, I'm Greg Sutliff. I'm the Finance and Operations Director at Project Access Now, and my pronouns are they, them, theirs. And I'm excited about being part of this group because Project Access Now, the organization I work for, serves many folks who have fallen through the cracks in the healthcare system and for whom, you know, the unaffordability and growing costs of healthcare are a real serious, you know, life jeopardizing problem. And so I'm very happy to be part of this conversation and part of trying to work toward solutions to that. So thank you.
Thank you. Pat.
Hi, I'm Pat Allen, he, him, his, Director of the Oregon Health Authority. My background's in economics, so I'm tempted to say that I'm excited by all of it. But if I had to narrow it down, I guess I would say for the what 11 or so years I've been around healthcare costs, I've been hearing that costs are going up at an unsustainable rate, and nobody's making any money in healthcare. So I'm really excited to maybe get some insight into how that can possibly be. Thanks.
Thank you. Karis.
Good afternoon. My name is Karis Stoudemire Phillips, and I'm the Vice President of DEI and Community Initiatives at Moda Health. And I'm most excited about this because as an insurer, we hear a lot of complaints and we want to be a part of the solution. So hearing the data and having these conversations with, looks like, you know, the folks that are assembled here are the ones that need to be having those conversations. So I'm glad to be a part of this group and really dig in and get down to the answers that we need. So thank you.
Thank you. Gil.
Hi, Gil Munoz, CEO of Virginia Garcia Memorial Health Center. He, him, his. Particularly interested, you know, as we're committed to the quadruple aim, you know, how do we start to address total cost of care while also addressing equity and quality issues for our population. So I'm excited about this group and also the connections that it has with value-based pay agreements as we see those moving forward.
Thank you. Ivy.
Good afternoon. I'm Ivy Dreyer Goldman, she, her. I really related to what Kalisa said. Thank you for that. I think it has been said that the #1 reason people lose their homes and go into bankruptcy is because of medical bills. I really want to see us reduce people's pain and the suffering that they have over medical bills. I think that's something that a lot of us have not experienced or will not experience, fortunately. And so many people do. I hope we can help.
Thank you. Angela.
Good afternoon, everybody. I'm Angela Dowling, President of Regions Blue Cross Blue Shield. My pronouns are she and her. I've been in this industry longer than I care to admit. And like Patrick, we hear a lot of challenges around affordability, and somewhere in this process, we need to find a way to look at this differently and solve this problem. It has been a problem for a long time, and affordability just needs to be something that we push forward. It's part of our mission. I passionately feel that way, and so I'm happy to be part of the conversation.
Thank you. Jason.
Yeah, good afternoon. Jason Hawkins, pronouns he and him, his, administrator in Peace Harbor, Peace Health Medical Center over in Florence, Oregon, and really excited to see how the data compares, the transparency, and mostly excited about how our rural health campuses can help contribute to slow the cost curve. So seeing what our role may be to help out our urban counterparts as well.
Thank you. Michael.
Thank you. My name is Michael Anderson Nathy. I use he, him, his pronouns. I'm an independent consultant who does a lot of work around health equity. I also have background. I did serve as a chief equity engagement officer for a coordinated care organization here in Oregon for a little over 5 years, and was a member of the health equity committee of the Oregon Health Policy Board for 4 years. So I'm excited to learn, because I think we're going to learn a lot here. It's going to stretch me, but I'm mostly excited to really think about how what are the equity impacts or implications, and really trying to figure out how we bring that and embed it into our efforts. So I'm excited to learn with all of you. So thank you.
Thank you. Mary Beth.
Hi, I'm Mary Beth Garino. I use she, her pronouns. I'm the healthcare advocate with the Oregon State Public Interest Research Group. And I was part of the implementation committee, so I'm really excited to be here on the advisory committee as well to see this work continue forward. We do a lot of work around medical debt and consumer costs, and this kind of work is really important to making sure that consumers are protected and not paying up the wazoo for their healthcare. So I'm really excited to continue that here with this group.
Thank you. Nick.
Hi, my name is Nick Powers. I am the CEO at Winding Waters Clinic out here in Wallowa County. It's a frontier county, and so I am excited to bring some perspective from far Northeast Oregon. And I lead an organization that sends bills to patients and gets paid by insurance and has to compete with other larger health systems. So I think we have a lot of experience with what's going on out here, at least on the east side of the state.
Thank you. Teresa.
Hi, I'm Teresa Learn, CFO with Care Oregon, use she, her pronouns. I'm excited about this work because I just see it as hugely important, really as part of a Medicaid plan, always looking to make healthcare affordable for all Oregonians, and really very committed to that. Also just really excited to learn from all of you and see what we can do together. So thanks.
Thank you. Julie, I think you're on the phone. Maybe on mute.
So, sorry. Julie Weller, she, her. I oversee plan design and strategy for U.S. benefits for Intel. We have a large contingent, about 26,000 employees up in Oregon. We have been a leader in driving change with our partnerships, our healthcare partnerships, to drive disruptive change in the healthcare system through innovation. So I'm really excited to hear the conversation, get the cross perspectives, and see how we can continue to improve our innovations as well as learn what we can do to support the state.
Thank you. Andrew, are you still on the line?
I am. Thank you, Sarah. And good afternoon again, everyone. My name is Andrew Stolfi. Use he, him pronouns. I'm the State Insurance Commissioner and the Director of the Department of Consumer and Business Services, which is the state's largest consumer protection and business regulatory agency. And I'm really excited to really dig into the relationship between the cost growth target and our annual commercial market rate review work, and how each of those processes can build off each other and influence and inform each other, and ultimately result in lower costs for consumers. Thanks.
Thank you. We have a couple more committee members, and this is a large committee who were not able to make it today. So just double checking, I don't think Morgan is on the line. Peter Davidson and Hirdesh Lal are all absent today, but we will hopefully meet them in July. Bill or Jeremy, I know you had the privilege of the opening remarks and sharing some of your excitement and enthusiasm, but is there anything you'd like to add to your introduction or your excitement about this work?
I'll just say thanks again to all the members of the committee. I know this is a significant time commitment, and it's going to be challenging work. There are no easy answers here, but it is something that I'm really pleased that this group has come together. And as I learn more about each of your backgrounds and the perspectives you bring, and particularly the what excites you about this work, I'm very encouraged. This is a great start, and I'm look forward to providing whatever kind of support that can come from the Oregon Health Policy Board, because this is such a high priority for the entire state. So thank you again. Thanks in advance for all the work we're going to be doing on this challenging topic going forward.
The only thing I would add that I'm excited about that I didn't say earlier is I really do think this data is going to be really vital, and I've had a lot of conversations with a lot of legislators and governor's office and staff and others around will this program really work or not? And my answer largely has been, I don't see a point of failure, because at the worst case, we're going to finally have better information about what's going on. And that hopefully will drive more policy conversations if the target in of itself doesn't succeed. And I think just the analysis we've done in the last year that Sarah's team's been doing is really, I think, starting to open things up. And I think we're realizing, one, as Michael talked about earlier, is stuff's extremely complicated. But also there's a lot that we haven't known, that we haven't had data for. And I think we're all going to learn a lot through the process. So thanks again.
All right. Thank you everyone so much for sharing. I think let's go ahead and take a break. We will reconvene at 3:45 for the second half of our agenda. We'll see you in a few minutes. All right, welcome back, folks. If you are here, please turn your video on just so I get a general head count before we jump right into some of the details. Okay, yep, looks like we've got critical mass. All right, next slide, Gerandi. Cool. Okay, so we are going to spend a little bit of time walking through the draft charter for the committee and some of the ways that we work together as a group. We're also going to hopefully either approve the charter today or identify any edits that are needed before you all are ready to sign off on the charter. And then we are going to talk about selecting co-chairs. So a little bit of housekeeping business about how we do business. So you all have a copy of the draft charter in its full 10-page glory. That's in the meeting materials online. We're going to go through a couple of sections of it in detail in the slides, but not every section. Next slide, please, Gerandi. One more. Okay, so to summarize the problem statement, which really summarizes everything from the opening comments and the data that has already been shared. Healthcare costs are rising and continuing to take up a larger portion of budgets. Not all of that cost growth is warranted. Prices are high and there's wide variation. So we've identified the problem statement. Next slide. And we have a vision and a mission for the cost growth target work and the cost growth target advisory committee. The vision being to lower the growth of healthcare spending in the state to a financially sustainable rate. And our mission is to measure total statewide health spending, transparently report performance, monitor key drivers of cost growth, hold payers and provider organizations accountable, OHA's strategic goal of eliminating health inequities by 2030, and slowing cost growth. Any questions or comments about the vision and mission? Okay, next slide. The advisory committee has a pretty broad charge. We walked through a lot of this in the orientation sessions, but just to recap, as a committee, your charge is to review and understand the cost growth trends and the cost growth drivers. So all of that analysis and discussion that we were just talking about earlier, identifying and addressing opportunities to reduce cost growth, exploring opportunities to improve equity, monitoring for negative impacts of the target, revisiting the cost growth target value for 26 to 30 as well as beyond 2030, oversee ongoing program implementation, informing public hearings. Next slide. Reviewing and understanding performance relative to the cost growth target. So how are we doing as a state? Reviewing and understanding progress towards our value-based payment goals, as well as any other strategies that we are pursuing as a group, as a state. Ensuring the transparency of the cost growth target program and the data, so helping hold us as a program accountable to that. And encouraging collective action across payers, provider organizations, and other partners to meet the cost growth target. So as Michael said, the target is just a number, and really we have to be thinking about these strategies and these ways to take action, and that is a major component of the advisory committee's charge. Any questions or comments about the charge? Okay, head shaking, great. Next slide. Okay, so a little bit on the committee membership. So as committee members, you were appointed by the Oregon Health Policy Board. You are appointed for 2-year terms. If you change roles within your organization, or if you change organizations, you may continue to serve on the advisory committee. That'll be at the discretion of the OHA director, so Pat. So if you end up changing roles, let us know, and we will figure out what that means for your continued work on the committee. Members may be removed for failing to fulfill duties, and we'll talk about what those duties are in a little bit. Members are considered public officials, so all of our committee meetings are operating under Oregon public meeting law, and we again shared in the orientation some of those expectations around ethics and conflict of interest for public officials. And then this is new, and we shared again in the orientation, qualified members may receive a per diem compensation for performing the official duties as an advisory committee member. So we were hoping that we would have the packet and all the information and forms for that compensation process ready for today. We're not quite ready to release that. The state's still working through some details of how that will all work, but we will let you know as soon as that's available. So for qualified members, and qualified is folks who do not work for a public institution and who meet an income threshold. You are eligible for a per diem for your work on the committee. Next slide. Let's get into some of the member duties and responsibilities. So we're asking you as members to agree to participate in good faith, to act in the best interest of the advisory committee, to collaborate to develop recommendations, to work towards conclusions or consensus that reflects the sense of the group, to reflect and integrate public comments into recommendations, to attend and participate in meetings to the extent possible, to review any materials before or after meetings as needed, to work collaboratively to explore issues and solutions, and to develop recommendations and documents as requested. So we will have some potential deliverables, and the policy board may request additional deliverables from us. So everyone working in best faith and in collaborative ways to fulfill those requests. Any questions or clarifications about member duties and responsibilities? Excellent. I will also add, and again, we shared this in the orientation sessions. We know that you are all, you all work in organizations and have that organizational representation, but you also have experience, whether that's your own personal experience interacting with the healthcare system, whether that is working in other organizations, and we're encouraging you to bring all of those perspectives and all of that experience and expertise to this work. So I think we are trying to be a little more open and fluid with that in this committee. And so you may want or feel more comfortable differentiating if you're speaking on behalf of your organization or on behalf of a sector versus reflecting some experience from your own personal experience, but we are open to all of that as part of your membership representation. Okay, those were the member responsibilities. Let's talk about the OHA staff responsibilities on the next slide. So to support you, we agree that OHA DCBS will assist by providing information, advising members, and staffing meetings. We will also act in good faith in all aspects of the process. We will do our best to support the committee to make informed decisions. We will meet with the co-chairs to set the meeting agendas, meeting facilitation, and preparing any content for you. So we envision that will be an interactive, iterative process. We hope to provide well-informed policy options for you. So if you say, we want to make a decision and we want to consider a range of things, bring us ideas, flesh this out a little bit, help us test this out, that would be our job to bring that back to you. And then we will be responsible for documenting decisions. So that will be in the meeting summaries, as well as other summaries of committee decisions, recommendations, reports, or other deliverables. Any questions? Is there anything missing from this list? Okay, you're all really quiet now and it's making me nervous, but hopefully that means the charter is in great shape. Next slide. So let's talk about some committee principles. So this is a little different than duties and responsibilities, but we are proposing that the advisory committee will be sensitive to the impact that high healthcare spending growth has on people in Oregon. I think we've heard many comments about that already just in your introductions. Align recommendations. Ooh, someone who is not on mute, can you please mute yourself? Thanks. Okay. Align recommendations where possible with other state health reform initiatives to lower the rate of growth of healthcare costs. This is something that's coming up a lot right now in our provider organization conversations, where we know that there are other initiatives. We have a primary care spending target in the state. We don't want any of our work from the Cost Growth Target Advisory Committee to conflict or disincentivize any of those other initiatives or recommendations or bodies of work. The Cost Growth Advisory Committee will promote collaboration across payers and provider organizations and encourage collective action in meeting the cost growth target. So as Michael shared earlier, and as we've shared in other presentations, we really see the cost growth target as pointing everyone in the same direction and having that shared value, that shared responsibility for addressing cost growth. Identifying and working to mitigate impacts on health inequities, and focus on the delegated charges and avoiding topics and recommendations that are beyond the committee's assignment. So this is something that we identified for the implementation committee, and we wanted to call out here again. So there are specific things that we might say, end up saying are out of scope or beyond the reach of this committee because of interactions with other policy or other agency or legislative decisions. So if and when that comes up, we will try to provide some clarification on any guide rails. Any questions, comments, suggested edits to the principles?
If I'm sorry.
No, go ahead, Lawrence.
Thanks, Pat. I think the principles and the charge and is very well drafted. So I don't take my comments as a criticism of anything you put down here. I did just want to note that and maybe this is captured in the avoiding unanticipated negative impact statements there, that not all costs and not all cost growths are bad. And that part of it allows us, part of that cost of the healthcare system, are the wages and benefits of the healthcare workforce of Oregon, and having a appropriately paid and adequately staffed healthcare workforce of nurses and respiratory therapists and pharmacists and food service workers and many, many other people is an important goal too. And I just wanted to just put that on the table.
Yeah, Lawrence, are you essentially proposing an addition of the Cost Growth Target Advisory Committee will recognize that not all cost growth is necessarily bad?
Something like that, something like that. That when I studied economics decades ago, they taught us that one person's cost was someone else's income, and that there is an ecosystem here that has to be supported too.
Pat?
There we go. Thanks. The fourth principle, as I read that, identifying work to mitigate impacts on health inequities, I read that to be, this work may make health inequities worse, and we should try to minimize that. I would prefer, if people are amenable, that it reads something more like identifying work to mitigate health inequities. That part of what we need to do, it needs to address health inequities, not that we're going to try to not make them much more worse than we have to.
Yeah, pull out the double negative. I saw a couple thumbs up and head nods there. Any reactions to either Lawrence or Pat's proposed edits? Other comments, questions, edits, suggestions? This is great. Mary Beth.
Sorry, I was trying to find the hand function. I think both of those are good. I think one thing to just keep in mind, and this may not need to be in the charter, or maybe it does, but anything that we do that affects cost will have effects elsewhere. And I think maybe I'm just rephrasing what Lawrence said, right? So just keeping that in mind as we're doing our work, that there are good costs and there are bad costs, and to make sure that when we're evaluating whether it's a good cost or a bad cost, or where we can come up with strategies to lower those bad costs, that we're keeping that in mind.
Thank you. Felisa.
Yeah, can you, I'm sorry, I'm having a hard time going through the materials that you sent out. I know it's on the staff responsibilities, if we could go back.
Yeah, Johnny, can we go back a slide, please?
I think that one of the, and if you go forward again, so I think on this last thing about staying in scope, I think one of the staff responsibilities is to connect, maybe make the connection across all of the work. So I'm happy staying in scope, knowing that maybe another committee is going to hear about or connect to the work that we're doing. If an issue comes up here, that's going to be addressed somewhere else. And so I don't know how to rephrase that in this mission, but I do think it's a staff responsibility to make that happen. And somehow to rephrase that bullet.
Okay, I think I follow you. I think what I'm hearing is a suggestion to add a staff responsibility and agency responsibility to help keep the work connected if it's happening outside of the advisory committee. That seems totally appropriate. Okay, other comments on the principles or the duties and responsibilities? Okay, well, let's go ahead 2 slides, please. Okay, so getting a little more specific into expectations for members, we are expecting that you attempt to attend all meetings, be respectful at all times, bring all aspects of concerns about issues into the process, refrain from personal attacks, and maintain a respectful tone in written communications. And I really want to emphasize this third one about bringing aspects of concerns into the process. So we're really hoping that if there are concerns about a direction or a decision or a recommendation that the advisory committee is considering, that you are raising those concerns in that process inside the committee, and not, say, writing an op-ed about why the committee is making terrible decisions. Not that any of you would do that, but I think we're hoping that we incorporate as much of that discussion and decision-making and concerns in the process itself. Any questions or comments about the expectations? Okay, next slide. For some communication expectations, as I said, try not to negotiate through the media or use the media to undermine the work of the committee, raising concerns at the committee meetings, and also hopefully members will agree that you cannot make decisions or promises about committee decisions outside of committee meetings. So this was something that came up a little bit with our previous implementation committee, where we had requests from various folks who wanted to meet individually with committee members. which you are welcome to do, but we just want to be really clear that decision-making happens in the committee meetings and not outside of that. Any questions or concerns about that?
I'm sorry, I'm having trouble finding the raised hand. Will you give us guidelines or tips for how we could communicate in writing between meetings with the work of the committee in the way that's most appropriate and helpful? That would be helpful to me, because sometimes there are issues that we could raise maybe to put on an agenda or not, or confusions that could be clarified easily if we could do it in an appropriate written way in between.
Yeah, definitely. I think if there's confusion or questions about anything for an upcoming meeting, that's totally fair to put in an email and we'll send around. I think just know that communication to and with committee members will be part of the public record. Okay, let's talk about decision-making on the next slide. So we are proposing and hoping to use a consensus model for decision-making. We're hoping that that is a participatory process, striving for agreement that you can accept, support, live with, or agree not to oppose. And that for the most part, if at all, for all of our decisions, if we can, that we would use this consensus process. If that consensus is not possible, or if a member calls for it, we can move to something to a vote. I think because we have such a large committee and we have diverse perspectives here, we want to avoid things just splitting down into a majority vote. And we think a lot of the discussions are going to be more nuanced than that, but we can essentially default to Robert's rules if necessary. But we're hoping to stay in consensus as much as possible. If we can't reach consensus, if we do end up going into that more formal voting, we will make sure that we're documenting any minority opinions and sort of showing the whole nuance of the conversation. This was something that really was important for the implementation committee, as some of the decisions around the structure of the program were being set up. And we want to make sure that we have that guiding our work here as well. Michael.
Yeah, thank you. I love that minority opinions will be documented, but I'm wondering if we can consider shifting or changing the language around the person with a minority opinion being responsible for solving the problem. I mean, I think as we've heard, this is very complex. It kind of puts the onus on solving complex problems on one person. And I think that, it's kind of all of our jobs to kind of engage with something, and we should be able to point out a problem or a challenge without knowing how to solve it, right? I think the other thing is that, this kind of approach of if you can't, oppose unless you have a solution is another way of kind of perpetuating status quo and kind of dominance. And so I would love if it just said that those with minority opinions are, expected to, engage or positively engage in a solution with the rest of the committee. I just don't want to fall on one person, and I don't want that to be the reason that we silence people.
Pat.
Yeah, can you remind me, are agency heads voting or non-voting on this committee?
Non-voting.
Thank you.
I think that is a great point, Michael, and we can look at revising the language here. I do think that where this came from, the context behind this approach is less attempting to silence anyone and more on the not wanting to enter a conversation where anything is just sort of thrown up as, oh, well, it's too hard to address that, or, oh, that's too much of a technical challenge, so we shouldn't do it. I think it's more that vein rather than silencing, but your point is well taken. Other comments, questions? I'd love to hear actually from folks who are on the implementation committee. That we struggled a little bit moving into more of a collaborative consensus model. And if you have any thoughts or feedback or suggestions for tightening this up, I'd love to hear your perspective. Lisa.
So I think one of the challenges is I feel like whoever is chairing the meeting has to understand how these forms of decision making work and how to collectively move a group through these forms of decision making. And I think I feel like it's the responsibility a little bit of the staff to help guide them through that process, but also I think, Bill, you're the chair, right? So you're going to run these meetings?
We haven't gotten to the chair yet.
Okay, so whoever's the chair needs to know how to work through these and like know when to move the process along. I think is really important, and identify which stage we are in.
Great. Stefan.
Yeah, and I'm sorry, I want to apologize again for, I have some really sloppy, really weird Zoom connection issues, so it's slower. And I'm kind of slow in like raising a hand and raising, and it's just delayed. But I just want to so note on this, right? So it's like, you know, it's like the decision of what, like how this, you know, how this committee is composed of might determine a lot of the voting and the majorities. And you know, that is at the end, that was your decision how you wanted to compose this, but you know, it can have some sort of consequences for how these majority votes might come out, and how many of these votes will happen also depends a little bit on the way that people might consider some sort of.
Oh, did we lose you?
I just noted. Yeah. So can you hear me now?
Yes.
So I didn't know where I stopped. Sorry. Now it's not choppy. So that's great. So I just want to say, like, you know, it's like one thing you can look at this and you can say, like, we try to do consensus. If it doesn't work, we do majority. You can also look at this like, if I don't like the consensus, where the consensus is heading, I'm vetoing it. And then I'm forcing a majority, and if I feel like I have a majority on that, you know, I can kind of force that, and that might end up a lot of these decisions. So, so it's really just a comment about how this, what the dynamic here will look like. It's a little hard to tell right now.
Thanks. And I think that really ties into what Felisa was saying about recognizing where we are in the process and the role of the co-chairs and the staff in guiding us through this. Okay. Other comments or thoughts on the consensus and voting? Okay, let's move to our next slide, which is potentially the first decision that we are going to make together. So we have a couple of options here. We can, there are a couple of changes that I heard requested that we will make. We can agree that you all adopt the charter, you approve the charter with those changes made. We can do that today. Or if you'd rather wait and see an updated draft with the changes incorporated, we can revisit this in our July meeting. Is there a preference?
This may just be my personal opinion, but I think the changes are pretty minor. And so I would be comfortable with just approving it with the changes made.
Okay, Michael agrees in the chat. Couple thumbs up.
Okay. I would agree if you could run through, Sarah, can you run through the changes?
I can attempt to. So we are going to add staff responsibility around keeping the work connected. We are going to revise the double negative in the principles around inequities. We are going to add another principle about recognizing the nuance in cost growth, that some cost growth is good and some cost growth is less good. Those were the big ones. And we're going to change the framing around the minority decision. Did I miss anything? Stacy, I know you're taking notes. Help me out here. Did I miss anything? Nope. Okay, great.
A really small thing under committee principles, the fifth one, the bottom one, I think there's a typo in that phrase.
I think you're right. We will also correct the typo.
Thank you.
Okay, so approved with those 4 changes and the typo correction. Are there any concerns or objections with doing that today? All right, all of your heads are shaking. I feel like there's consensus. I know I'm not doing this as formally as maybe I should be, but feeling okay with that. Are we ready to move on to co-chairs? Okay, I've got thumbs up, supports. Thanks, everyone. All right, let's talk about co-chairs. Next slide. So for co-chairs, we are revising this a little bit from how the implementation committee chairing went. So what we're proposing for the advisory committee is that we'll have we'll have 2 co-chairs. They will share power and responsibility. They will encourage the participation of committee members. They will assist with the consensus building and that facilitation that Lisa mentioned. They will ensure that members abide by the expectations and the group agreements. They'll work with staff to develop the agendas, facilitate the meetings, and ensure effective decision-making process. When needed, they will serve as key spokespeople, whether that's reporting back to the policy board, the legislature, meeting with other stakeholders, possibly with the media as it comes up. And next slide. We would like, we are proposing that one of the co-chairs will come from the healthcare industry and the other co-chair will come from our non-healthcare industry members. So again, maintaining that balance in voice and representation that we have on this group. So before we talk about if anyone's interested in being the co-chair, let's go back one slide. Are there any questions? Does anything seem missing from the co-chair duty and responsibility list?
Sarah, just in terms of the consensus building, if we can't reach a consensus, will they also help with the vote?
Yeah, calling for a vote. Yep, we can add that. Okay, seeing no other comments on this, let's go forward again, Gerandi. Okay, so let's see how easy this is. So we can see right now if there are folks who would like to self-nominate to be a co-chair, and we can just get a pulse check on level of interest today. If that's a very clear, easy, only 2 folks are interested in it, maybe we can be done and we'll have our co-chairs for July. If we have lots of people who are interested and lots of people who want to throw their hat in the ring, we can come back to this in July once we know who's interested. Similarly, if nobody is interested, we will work with some folks offline to drum up interest and come back to this in July. So let me pause and see, is anyone interested in serving as a co-chair? Oh no, it's crickets. Okay. One of our other options, if folks are not interested in nominating, we can also ask the policy board to appoint our co-chairs. So Bill, start thinking about your involvement here. I think let's not spend a lot of time on this, but I encourage people, if you are interested and would maybe like to think about it a little bit more or have questions about what being a co-chair might involve in terms of a time commitment, just give us a heads up over email. We can talk more about it there and potentially come back to you with some potential nominees for our July meeting. Sound okay?
I'll just say that while there would be some additional work, it also, I think, is an additional responsibility. It's an opportunity to provide some important leadership to this group, but also that the staff will provide lots of support for you. It's not like hanging you out there on your own to do everything as co-chair. So I would encourage those of you who are interested, please reach out to Sarah, and we'll work with you to make it work for you and the whole committee.
Thanks, Bill. All right, let's move on. We'll come back to the co-chair in July. Next slide, please. Okay, so we've talked about expectations for individual members. We've talked about the co-chair's responsibilities. We've talked about the staff's responsibilities, but we want to spend a few more minutes today talking about how we work together. And this is sort of going a little bit beyond some of the principles and agreements and the consensus building or consensus decision-making model. Group agreements are something that we've been working on internally in a number of OHA teams and projects, and want to bring some of that to the committee process as well. So group agreements are behaviors and actions that we all agree that we will exhibit, that we will bring to this work as we are working together. They're sort of a mutually agreed on list of things, and they're something we can reference back to, especially if we're getting into any sticky conversations or sticky debate. We can reference this back to give us a little bit of guidance. It also can be revised. These group agreements can be revised and added to at any point as needed. So next slide, please. We are proposing a couple of starting places for group agreements, but then I'm going to open it up for your reactions and either edits to these or additions. So the framing that we propose is how do we engage in order to do our best work? And our group agreements would be that as a group, we will actively listen, share ideas and opinions, ask questions, be open, be respectful, trust intent and explore impact, and be timely. Are there any thoughts that people have about this? Those of you who have used group agreements in other settings, and I know some of you have, I really welcome your feedback here. Mary Beth.
I think we might have covered this in another part of this document, but maybe not. Just do your best to review the materials before the meeting so that we can have the best discussion possible during the meeting time.
Heidi?
I would say it sounds pedantic, but be mindful of biases or consider biases.
Okay, great. Nick?
I think since we're seeking to use a consensus model as much as possible, it might be worth having something in here about testing for consensus relatively frequently, and as an opportunity to encourage people to share their ideas and opinions, not just hope that they will.
I like that. Lawrence.
This may be under staff responsibilities, but if we could always have at least one weekend to read the materials ahead of time, it would be, we've tried to do that in group processes, and it would be a great help.
Okay. We will try our best to get you materials in a timely fashion. Julie.
Just curious, is there any expectation of confidentiality of the conversations that are had? So somebody shares openly about, like I said something about it, Intel does, that it doesn't get spread around. Can we presume that, or is that not expected here?
I think given that these are public meetings and everything is being recorded, that we should not presume that, but
okay, that sounds fair.
To raise and double check.
Just want to make sure.
These are great additions. Are there other things people would add or revise? Okay, I think what we will do is update this list a little bit, and we'll just have that as a working document. We might append it to future agendas just to keep that sort of top of mind or keep that refreshed for us as we move forward together. Thank you for your feedback. And if anyone feels like we need to revisit this at any point, just let us know and we can do that. Okay, thank you for bearing with me through all of that. We have a couple more housekeeping details. Next slide, please. Just reminding everybody that we have 4 committee meetings scheduled for 2022 today, July 19th, September 9th, and November 9th. All of these meetings will be virtual. All of these meetings will be public. We will continue to meet in 2023. The plan would be to meet every other month or possibly once a quarter in 2023, but we have not yet scheduled. I think sometime in November, we will begin reaching out to you or to your assistants to help with calendaring and getting all of the 2023 meetings on the calendar. So I think we accidentally made it sound like your commitment was only for these 4 meetings, but that is not true. We will continue meeting in 2023 and we'll be scheduling with you later next year. I know that there were also some questions in orientation about whether or not we would ever meet in person. I think there is some interest in potentially getting together face to face. I don't know if and when we will do that. So I think we're committing to doing virtual meetings for the rest of this year, and then we'll assess for next year what makes the most sense. Especially because we've got folks from all over the state and in some cases out of state. Virtual may be the best way for us to continue to convene, but just recognizing that request to potentially get together at least once face-to-face has come up. Any questions about the meeting schedule or next year's meeting schedule? All right, Jim is signing off. Thanks, Jim, for joining us. We'll see you in July. All right, let's go to the next slide. We also shared this in orientation, but just a reminder, what we're going to be covering in our July, September, and November meetings. We're going to start reviewing some of that cost trend data and cost driver data. We are going to be talking more about accountability mechanisms, so both the performance improvement plan and financial penalties. So how are those calculated? How do we set those at the right and appropriate levels? We're going to talk more about provider engagement, and we're going to spend a lot of time talking about how we take action. What are those strategies that can help us address cost growth and address those cost growth drivers? So we're going to start in our July meeting talking about value-based payment and hearing an update on the value-based payment compact work and what that means and how we keep that momentum. And then we'll also be talking about other strategies that might begin emerging as we review data. So that is what we're hoping to cover between now and the end of the year. Any questions or comments about that? Okay, and next slide for our final housekeeping notes. As I shared, OHA is still working on that process for compensation. Compensation will be retrospective, so please track any days that you are performing work for the advisory committee, so including going to the orientation session, today's meeting, and you only need to track days, you do not need to track hours. So we will get that reconciled with you once those forms are available, but more to come, and just please generally track your days. Okay, any questions or comments about any of the committee operations, anything that you might want to know or that we didn't cover about expectations for now through the rest of the year? Lawrence.
Maybe I misread this, but there seemed to be some mention of 2-year terms, but starting with staggered terms. Do we know?
Yeah, the way that we've done this on previous committees as they're first starting is as we get close to the end of the initial 2-year term, we'll check in with interest and likely extend a number of members for another year so that we don't have a complete turnover of the committee.
Okay, but no one's less than the initial 2 years.
No one is less than 2 years.
Thank you.
Yep, great clarification. Anything else? Jeremy, is there anything else that you would like to add?
Oh, I didn't realize I was off camera this whole time. Sorry. No, I'm good.
All right, great. Then let's go ahead and move to our next agenda item. So we are actually a little early for public comment. I don't know that anyone has emailed or said that they would like to provide verbal public comment. So if you are on the line on the meeting today and would like to provide public comment, can you raise your hand or drop a note in the chat that you would like to do so? And while we hold space for that for a minute, I just want to draw everyone's attention to the public comment in writing that was submitted this morning by the Hospital Association. I emailed that out to committee members. It is also posted on our website for committee meeting materials. So I encourage you to take a look at that. Actually, and this is more of a housekeeping thing, Bill, Pat, and Jeremy, maybe actually I can ask you to reflect on this too in a second. One thing that the policy board has started doing lately, which I really like and would love to bring to this advisory committee to adopt, is the sort of framing around public comment and having the committee take an active listening role for public comment. So we hear you, we're not necessarily responding to it in the moment, but we will take it into account and if needed, follow up. Bill, Pat, Jeremy, do one of you say that better than I did about how the board approaches that?
I can take a crack at that. I have served on a number of public bodies, including a planning commission and a school board, where we've all used that kind of a structure, and it I think keeps you all in the listening mode rather than kind of gearing up to think about what your response is going to be or what arguments might be. I think sometimes it takes a little bit of forbearance to not want to jump in when you hear something that you strongly disagree with. But again, if we all stay in that listening mode, then we're really openly listening to comment rather than thinking about how to respond to it.
Yes, I agree. I think this is a good practice. And the important parts are, first of all, that all public opinion or public comment is received in a respectful way. and that the members of this advisory committee will commit to listening and hearing the perspective of those offering public comment, but that we will refrain from making any response to those. When I say we, the committee here will refrain from making any comments in the moment, as Sarah and Pat said. There may be a response warranted, in which case the staff would craft something and working with the co-chairs figuring out the appropriate response, whether it's in writing or however. But that's what I think that is a best practice, and would strongly recommend that the advisory committee adopt the same kind of guidelines that the Oregon Health Policy Board has used.
Thank you for the additional details. I don't know if this warrants sort of official adoption, or if this all makes sense to folks. We can generally agree to use that framing for receiving public comment going forward. Any concerns or questions about that?
I think so. I think having given a lot of as equitably as disrespectful. And so, especially in a virtual environment where you can sort of stare at people's faces while on little boxes, how that looks and how we present, I think is really important. So I just want to keep this open to revisiting how we engage with people and how that's going.
Thank you. Other comments on this? I'm also not seeing any hands or seeing anyone in the chat indicating that they would like to provide public comment today. So doing maybe a last call. If there's anyone on the line who would like to give public comment, please speak up now. And then I think with the active reading framing, maybe I would encourage committee members to please take a look at the written comments from the Hospital Association. And if there are any follow-up questions for them, you can let us know as staff and we'll coordinate that with them, or coordinate if you want to invite them back for some discussion.
Just one follow-up, expanding on the guidelines. I believe in the Oregon Health Policy Guidelines on public comment too, that any responses would be made appropriately by the committee or the committee co-chairs, perhaps probably working with the Oregon Health Authority staff, but that individual committee members would not be expected to respond to any public comments. Is Pat, Jeremy, could you confirm that? And does that make sense to add that, or to include that in the guidelines that this advisory committee uses?
Are you asking if you want to incorporate that as a ongoing practice? I think that's fine and appropriate.
All right. I am not seeing any. Oh, go ahead, Greg.
Yeah, I'm just wondering if it's necessary to talk about like the procedure involved in drafting a response and get like, would the response be drafted by staff or the co-chairs and then circulated to the entire committee to try to deter in an instance where it makes sense to do that to kind of get buy-in from everybody before sending it out, or would it be put on the agenda for the subsequent meeting, or just wondering about that.
I'm actually, this is a really interesting question, because if I think back to the implementation committee experience, I think all of the public comment that the committee, quote, responded to, the response was by incorporating changes into the committee deliverables or the committee decisions. It wasn't a direct response back, like a letter back. So I'm trying to think like, oh, do I envision a scenario where the committee would want to send a response back? And I don't know. I would be open to that, but it feels like that might be less necessary than it is in some of the policy board conversations.
if I could suggest, I would think it would be rare, I would think, because as you observe, the committee's work is the response. You know, you did or didn't take into consideration what you heard. But I can also imagine, that's probably what Bill was thinking about, that something gets said that can't go unanswered. Hard to imagine what that would be. I would think it would be really rare, and then I think what happens next is something the committee probably probably talks about as part of that meeting, not in response in the moment to the comment, but thinking about what comes next. And it would really depend, I think, on what the committee feels it's necessary to respond to.
Okay, anything else on public comment? Feels like we're about to end early, and I didn't expect that. So let's go ahead to our last slide, please, Drondi. Just to wrap us up for today, all the way to the end of the deck. Okay, so our next meeting is July 19th at 2 p.m. Pacific. We will send you the materials, hopefully about a week in advance, so that you have a weekend to review them if needed. Our tentative agenda is to review some of that cost trend and cost driver data, and to have a discussion and an overview of the value-based payment compact and how we're doing in terms of progress towards value-based payment targets in the state. Let us know if you have any questions, any thoughts, any concerns about anything we've talked about today. Let us know if you would like to self-nominate, or maybe we'll mix it up. If you'd like to nominate one of your fellow committee members as a co-chair, send us an email and let us know if you're interested in that, and we will do that in July as well. All right. Bill is not on the committee. Final comments, closing comments from anyone? Jeremy, do you want to have the last word?
I think Bill heard enough for me today.
All right, then thank you so much, everyone, for your participation and your engagement today. I'm really excited about all of you on the committee and working with you and our next 2 years together. So again, thank you, and we will be in touch.
Thank you.